for our today's session.
Yes.
So thank you everyone for making time for today's RePaDD seminar session. With us today, we have got Dr. Sara Javanparast as our speaker. So Sara is the RePaDD fellow who joined us in May this year, and she has over 13 years of research experience in primary healthcare access and equity and community engagement. And in her talk today, Sara will talk about the concepts and conceptual frameworks around equity and social determinants of health, and how these mean what they mean in the context of palliative and end-of-life care. She will also talk about a small project that she has started in RePaDD that aims to assess the extent to which equity is considered in the national and South Australian palliative care policies and initiatives. We're really looking forward to knowing a bit more about your project and the focus of equity and social determinants and diversity in palliative and end-of-life care. Sara, so over to you. Thank you very much.
Thanks a lot, Priyanka, for your introduction, and hello and welcome everybody. My name is Sara Javanparast, and my presentation today is titled Equity and Social Determinants in Palliative and End-of-Life Care. All right, so here is an outline of what I would like to talk about today. Firstly, I would briefly introduce myself, as I'm relatively new to RePaDD. And then I would talk a little bit about the definitions and concepts around equity and social determinants of health, and some of the conceptual frameworks that have been developed to better understand these concepts. And then I would like to have a conversation, mainly as a group, on what these mean in palliative care and end-of-life care space, and what have already been done around equity-oriented policies, practices, and research, and also ways forward. So this is a little bit about myself. I joined RePaDD in May this year, as Priyanka mentioned, so just thought that I should briefly introduce myself and a little bit about my research interests and experiences. So I'm originally from Iran. You may have already noticed that from my accent. I have a medical background and worked for almost 8 years in Iranian primary healthcare network. Also worked for a few years in Iranian Ministry of Health when I was involved in primary healthcare policies at more national level, rural primary healthcare programs, and community-based health workers. I moved to Australia in 2002 and did my PhD at Flinders, which had a focus on primary healthcare interventions to improve access and equity, mainly in child health space. And since then, I've been involved in public health research, which was mainly on primary healthcare research, community development, public health policy analysis, equity and access, especially for marginalized population groups, including people from different cultural groups, and social determinants of health. And that includes my almost 9 years of work in the Southgate Institute for Health, Society and Equity at Flinders University. And between 2011 and 2014, I was the Deputy Director of the South Australian Community Health Research Unit, which was the evaluation arm of the SA Health. And during that time, I worked with a range of government and non-government organizations to evaluate different health-related programs and projects in South Australia. So I'm starting with some definitions, but I'm sure that you're all familiar with these concepts around equity and social determinants of health. And here is how the World Health Organization Commission on Social Determinants of Health has defined health equity. It's as the absence of unfair, avoidable, and remediable differences in health among population groups defined socially, economically, demographically, or geographically. And the social determinants of health are all those non-medical factors that influence our health outcomes. The conditions in which people are born, or grow, work, live, and age, and the wider set of forces and systems that shape the conditions of our daily life, which could be as broad as the social policies, political like context, and public health policies, and all the social norms and values. So where we live, the education that we receive in our early childhood, or income, or family environment, or gender, culture, or access to health and social services, all are examples of those factors that influence our health outcomes in life course from birth until we die. And there are very strong evidence out there showing that people who are less advantaged in terms of socioeconomic position have worse health and shorter lives than those who are more advantaged. And a good example is what we currently see in relation to COVID pandemic. There is a strong association between social and demographic factors and COVID-19 incidence and mortality around the world. And to understand these concepts, I really like this cliff analogy that Dr. Camara Jones uses. She's an American physician and epidemiologist, and also activism that uses this to illustrate the root causes of inequities and why public health strategies need to move beyond individual services to address social determinants of health. And it's actually a nice way to contextualize the health equity framework. So if you think here is this cliff and you have all these health interventions, you have a bunch of people standing really close to the cliff, and sometimes something happens to them, they get sick and they fall down off the cliff. They fall until they get into the flat valley. We don't want to this happen, and we want to somehow catch people and to help them. So in F, we put an ambulance down there. So if someone falls, there would be an ambulance to help. But to help them more, in G, we come up with an excellent idea and we put a net halfway down. So if they could bounce, and hopefully they don't fall through that cracks, but because there are holes and cracks, they may slide through. Even if they bounce back, they may not be able to reach the top of the cliff. So what else can we add as a health intervention? How about putting a fence in H, so preventing them from falling in the first place? It should be a very strong fence because there's a lot of population out there. And other thing we can do as a health intervention is to move the population away from the edge, as you can see in I, so they are not even at risk. So now let's label all these interventions. The ambulance at the bottom of the cliff represent the acute medical care to treat injuries among those who have fallen. The net in the middle is the safety net, the secondary prevention to prevent injuries among those who have fallen. The fence on the edge is the primary prevention and primary care activities to reduce the risk of falls, which is mainly reducing risk at individual levels. And moving the population away from the edge in public health is about addressing the social determinants of health and reducing the risk at community level and at population level, and all the factors that are beyond the individual level behaviors and are related to the context within which people live, like or neighborhood or educational opportunities or income opportunities and so on. So far, this diagram has shown different levels of intervention, but it doesn't show how health inequity arise. So in here, in A, you see a two-dimensional picture, and we are not living in a two-dimensional world. We are not made of one community as it is shown in A. We are living in a three-dimensional world and we are made of several communities with many differences in access to care, quality of care, and exposure to different risk factors. So here in B, we see two communities. They are both back from the fence. They have fence at the edge, and they have nets, and they have ambulances. But in C, the ambulance closer in here, it has a flat tire. So if somebody falls, that ambulance won't be able to give them the care they need. Or maybe in D, there is no ambulance waiting for them at all. Or in E, they may not have the ambulance and the safety net to catch them. Or in F, not even have a fence. And usually for these population, they are usually pushed closer to the edge, as you see in G. So meanwhile, the other community is still doing well because they have all the preventative measures plus primary and tertiary care. So let's label this three-dimensional cliff to see how inequity arises. The differences in quality of care is represented by the ambulance that is there but has flat tire. Differences in access to care, no ambulance, no net, no fence, and differences in underlying exposures and opportunities are represented by the population standing closer to the edge of the cliff. And usually when you talk about health services are what comes to mind first, the fence, the net, the ambulance. And we acknowledge that we do want an accessible and universal and high quality health services for all. But social determinants of health is how far you are from the cliff, and to address that, we do need to address the contextual factors to have high and sustained health outcomes. And social determinants of health equity is not just how close or far you are from the cliff, but also the services that you have to have. So now, having these concepts in mind, which are mainly underpinned by social justice and human rights frameworks, many conceptual frameworks have been developed to help a better understanding of the very complex interactions between different contextual, organizational, and individual level factors in addressing inequity and social determinants of health, and to also guide policymaking and make it clear that which type of actions are needed to address inequity. And one of the most commonly used framework is the one that the World Health Organization developed as part of their extensive work on social determinants of health. And this framework shows how these social, economic, and political mechanisms and contexts lead to social class divisions in the society and socioeconomic positions, where populations are stratified by income, by their education, occupation, gender, race, and ethnicity, and other factors, which in turn shape specific determinants of health, which called intermediary determinants here, and their access to power, services, and resources. So basically, these structural determinants that we see in the left side are referred to social determinants of health inequity that operate through a set of intermediary determinants such as living and working conditions, psychosocial factors and stressors, social supports, and so on, to actually shape our health outcomes. And the WHO framework actually conceptualized the health system itself as a social determinants of health and highlights the role that health systems can play in improving access or reducing exposure, and also through intersectoral actions that can be led by the health sector. And using this framework and turning that into policy actions, they actually identify different level approaches. So some activities and actions are targeted programs at more individual level for disadvantaged populations. Secondly, programs that aim to close the gap between the worse off and better off groups, and also Another level of actions are those who address the social health gradient across the whole population. So all these actions can complement and build on each other, and they are all also underpinned by working together and intersectoral action, and also social participation and community empowerment. There are other conceptual framework that I also found useful, is the one that is developed by Lewesky and colleagues, which focus more on access to healthcare and conceptualize access at the interface of health systems and populations. And the framework looks at the dimensions of accessibility from supply side, such as health systems, institutions, organizations, and health providers, which interact with demand side abilities, which is more at individual, household, community, or population levels to improve access. And in the supply side dimensions, it includes approachability, and it's the fact that people can identify that some services exist and can be reached, and elements such as transparency, information about the services, and outreach activities, they are all linked to approachability. But in reality, some services can make themselves more or less known among various social and geographical population groups. The next dimension is acceptability, which relates to professional values, norms, or even their gender. That it means that some services are inequitable in a way they are organized, making them unacceptable to some population groups. Then we've got availability and accommodation, which refers to the fact that health services can be reached both physically and in a timely manner. So their geographical location, like services that can be provided after hour, the appointment mechanisms, all these sort of things. Affordability, which is about economic capacity for people to spend for services. And finally, appropriateness, which is more about the technical and interpersonal quality, adequacy, and care coordination and continuity. And at the bottom, you see the demand side dimension, which is ability to perceive. So it's more about people's health literacy and health beliefs and trust of health system and expectation. It's about ability to seek, which relates to concepts of personal autonomy and capacity to seek the services that they need. The ability to reach, which is more about personal mobility, the availability of transportation, occupational flexibility, and social support. Ability to pay, which describes the capacity to generate economic resources to pay for their health services, and ability to engage, which is more about community empowerment and their involvement in decision-making and treatment decisions. And this last one is a framework that we developed as part of an NHMRC-funded project when we worked with 61 primary health networks across Australia. And we looked at the population health planning, the regional planning processes and strategies, and the extent to which they are equity-oriented and address social determinants of health. And what we found here is that for primary health network as Australian regional primary healthcare organizations, to be able to address health inequity, they need to have equity as an organizational goal and aim, and they need to have equity information and being able to collect equity-related data. They have to embed community participation and empowerment into their activities. And then all these need to be translated into effective strategies and action plans to improve not only equity of access to local health services for disadvantaged population groups, but also access to other health and social services, to address inequity in quality of care, to incorporate equity-sensitive health promotion activities, to collaborate with other health and social sectors, and also to contribute to broader advocacy work on social, political, and cultural determinants of health. And finally, the ability to actually evaluate the equity impact of all these initiatives. And what we found in our study was that the interventions mainly focus on access to health services for underserved population, and less was done to address the structural determinants of health inequity. Okay, so that was just an introduction of the concepts, but what will these mean in the area of palliative and end-of-life care? Adding an equity and social determinants of health lens in palliative care is actually considering them at different levels, at policy level, at practice and service level in palliative care research, and also in any kind of evaluation that we are doing around palliative care. So at policy level, it's important to see to what extent the political context is supporting of equity and the accountability of for equity in policy space. How much funding and resources are allocated to equity, and basically who benefit from the policy. Does it decrease or actually increase inequity? And also about collaboration and engagement with different stakeholders in the process of policy development and policy implementation, and also the knowledge about equity and the evidence that used to inform the policy. And similarly, at the service level and practice level, is it about identifying the equity groups? It could be about capacity building and training and education around equity and cultural competency in providing services. The extent to what the community are engaged, are involved in the service provision and the design of services, access to equity related data for services, and of course, equitable distribution of funding and resources. In the research space, it's important to have a think about what all research priorities are, and all funding, whether or not they consider equity issues, and the extent to what in the design and implementation of our research project we engage with or target population, and we use it through co-design approaches, and different research project on creating evidence on disparities in access to palliative care, digital health equity in palliative care, barriers to access in palliative care, and different models of care that address inequity and social determinants of health. And a lot has already been done around equity and social determinants of health in palliative care. So this is just an example of a recent paper published in 2021 that looked at social demographic disparities in access to hospice and palliative care. And they actually use that accessibility framework, looking at acceptability, availability, affordability, and appropriateness. So what they found that 70% of the study that they reviewed, they describe differences in outcomes by race, ethnicity, socioeconomic status, and the variables like age, gender, and geographical location, they were all important in disparities in access to palliative care. And also other studies looking at more national level, looking at equity in provision of palliative care in UK, or doing equity impact assessment of policy documents, which in this one is end-of-life care strategy in the UK, that there was an equity impact assessment done in 2008. That's a bit old. And there's also research around the importance of social capital and cultural determinants of end-of-life, and how much social relationships and networks impact on the quality of life for people at the end of their life. Then we've got the Australian government series of report that published in 2019 that looked at barriers to palliative care amongst 9 disadvantaged population groups that are listed here. And they reported a range of consumer side and service side barriers that highlights the importance of social, cultural, and economic determinants of palliative care, but also issues around health service availability and workforce, cultural awareness and training. And then we've got the latest Australian National Palliative Care Strategy, which has an increased emphasis on access and equity to palliative care for underserved populations. And it talks about different barriers, the geographical, cultural, language, and other barriers that hinders access to high quality palliative care, and has a focus on Aboriginal and Torres Strait Islander people as one of those equity groups. And it also highlights the importance of engagement, inclusion, choice, quality, culturally safe services, as well as investing on research and evidence. And I also found a recent study on how bringing in an equity lens to palliative care is particularly important during COVID, as there are growing evidence that those who are socially disadvantaged are likely to be among the hardest hit from COVID. And this is a work done by a community collaborative led by the University of Victoria called Equity in Palliative Approaches to Care, who conduct research and develop tools and resources aimed at improving access to quality care for people facing end of life and those who face like racism, social isolation, or homelessness. So now I would like to talk a little bit about my own small project when I started in RePaD, and thanks to RePaD for funding this Kickstart project, and also thanks to my colleague, Dr. Juliana, who is helping me on this project. And what we are aiming to do in this, to do an equity focused assessment of the national and South Australian palliative care policies, initiatives, and evaluations, and to see ways that equity is defined in these documents, and what evidence are used to inform policy, what are the organizational capacity for equity-oriented projects and initiatives and policies, and also translation of this equity goal, if any, into palliative care strategies, action, and investments. We also intend to do interviews with key stakeholders to identify evidence gaps and research priorities that can inform equity-oriented palliative care policies and practices. And what we did, we looked at 25 documents in the last 5 years, so we looked at more recent documents. And they include different types of documents, so including policy documents like the National Palliative Care Strategy and Implementation Plan, and South Australian Palliative Care Plan, and a strategic framework. But also we included some larger evaluation reports that evaluated the like national palliative care projects and initiatives, and also a number of projects and initiatives that was funded at national level or in South Australia. And also we included some other documents that we thought might be relevant, like those 9 reports that was funded by the federal government to identify barriers to palliative care in 9 population groups, a couple of budget documents, and also the Royal Commission report and recommendations. So what we did, we created a coding framework to look at different aspects of equity and some subcodes. So going through all these documents and see whether or not specific disadvantaged population groups are prioritized, or any strategies or actions that are proposed or implemented to address the inequity in access and availability and affordability of palliative care services, the extent to what there's evidence of engagement with community groups in the design and implementation of palliative care services and programs, whether or not there is any evidence of equity-focused research and equity-focused funding, whether it's in research or whether it's in services and different activities. We also looked at intersectoral collaboration, if there is any evidence of vertical and horizontal collaboration in palliative care, the actions that are proposed or implemented to improve collaboration, any funding to improve collaboration, and also in all these things, whether or not there are any strategies to monitor and to evaluate inequity in the policies and practices. And finally, social determinants of palliative care. And what we looked, whether in any of these documents, social determinants are acknowledged explicitly or implicitly, and any evidence that use around social determinants of health, and any strategies or actions that is proposed or implemented. So that's the initial coding framework that we created to review and to analyze these documents. It's a work in progress, so we just finished like the initial step of looking at the documents. So it's just very preliminary findings that we found so far from first level analysis, if you like. And what we found is that the equity and illness groups, it's most commonly coded in all policy documents, and it mainly coming from those series of reports that looked at the barriers to palliative care amongst non-population groups, but also in other documents and policy documents, they talk about specific underserved populations. And the only place we saw in South Australian palliative care plan that they broaden out the scope of disadvantaged group to include discussion around social gradients and social determinants. And the strategies that or proposed actions that mentioned to improve equity was more about information and awareness, flexibility in models of palliative care is needed, more research, evaluation and monitoring, and financial support and resourcing. And the evidence on social determinants of palliative care or any talk about it is mainly coming again from those series of reports on barriers to palliative care in specific population groups, where they talk about specifically and explicitly talk about location, housing, health and death literacy, stigma and discrimination, trauma, communication and language, cultural and religious determinants, and financial disadvantages. And the areas that are less evident is around intersectoral collaboration, which we found little evidence on proposed or any actual actions for collaboration with other sectors to address social determinants of palliative care. There are some talks about vertical collaboration and the importance of collaboration and integration between primary care and tertiary care in providing palliative care, but not much around horizontal collaboration or working with other sectors in palliative care. And equity-focused funding allocation was one of the areas that we found less prominent in our document review. And equity-focused evaluation, because we included a number of national evaluation reports in our review, what we found was that equity was not included as an evaluation domain. So it wasn't used as a lens to look at the how those like projects or programs reach their outcomes. So what's next? So as I said, that's a small project and the scope is limited. So we continue to analyze those documents, but we're also interested to look to identify and do some interviews with key informants in South Australia to explore their perceptions about equity and social determinants in palliative care, but also finding evidence gaps and research priorities from their viewpoint. And probably in future research to kind of expanding what we are doing now, looking back at the history of palliative care policy context and the changes over time and why. So what's been the movement in terms of looking at incorporating equity in policy context, and what regulatory forces and actors or ideas around equity are driving these policy changes over time, if any. And also would be interesting to make to do a comparative analysis of palliative care policies and practices in different jurisdictions to see how they are different concerning equity and why. And finally, the aim is, what I'm very passionate about, to see what are these evidence gaps, what are these research priorities, and how we could build on our current research to develop streams of research around equity and social determinants of palliative care that is theory-driven, that engage with communities through co-design approaches, and the research that is applied and is able to inform and to be translated into policy and practice. All right, so I think that's all for me, but what I like to I really like to get out of this session was to learn from you. And from here, I would like to stimulate the conversation and actually like to learn more from you who have far more knowledge and expertise than me in the area of palliative care, death and dying, about how inequity and social determinants of health are addressed in palliative and end-of-life care in Australian policy and political context, practice and research. And like the thinking of examples of equity-focused policy, strategy and programs that you have been involved in or you're involved in at the moment, and how do these actions actually fit into the equity and social determinants of health framework. What strategies you think should be considered to move towards more understanding of equity and social determinants in palliative care and end-of-life care space. And of course, what research should be prioritized to inform equity-oriented palliative care. So I finished a bit earlier just to give more time for this conversation and for you to be able to share your thoughts and your insight and like sharing the things that you think if you put an equity lens into it. Thank you so much. So I really am looking forward to hearing from you and also comments from you and answering any questions that you may have. Thank you.
Thank you very much, Sara, for a great presentation. And I think that's a great way of utilizing a bit of time for that conversation. May I ask if you could flick back to the slide with the questions in them, and we might sort of try and get some engagement from the audience to see, if you would like to share any thoughts or any comments or any experience, any viewpoint in relation to these questions. And that might be really helpful for Sara in terms of understanding what work you're doing or where you're sitting and, what your thoughts are. So I'd like to open it up to the floor and let's get the comments, answer to the questions or just feedback coming.